Might we see psychosis in bipolar 1? Yeah, we might. Is it required? No, it's not required. Might we see psychosis in bipolar 2? No, we will never see psychosis in bipolar 2. Because it's not allowed. Would we see it in cyclothymia? No. PET scans look at the regional cerebral blood flow to see the activity level in the brain. Someone who is not in an episode of major depressive disorder, you can see where it says not depressed, that's the frontal lobe up there. We're looking down, so we're looking at the right hemisphere, the left hemisphere. You can see when someone who's depressed, it's not as colorful because there's not as much activity in their brain. That's very significant. Okay, so you see not depressed, you see depressed. Red and yellow mean highest activity. How do we know the brain is behaving in significantly different ways when someone's got major depressive disorder and in the middle of an episode, and if someone's got mania in the middle of an episode, or none of those? Because we can definitely see that the blood flow patterns are different. When we talk about any of, see, not always, but sometimes we have specifiers. We do in the case of bipolar 1. We could use specifiers in persistent depressive disorder, in bipolar 2 disorder, but when we look at the research, they're generally referring to major depressive disorder and bipolar 1 disorder. Our capabilities are pretty good at those two. When the research says we looked at, bipolar disorder, major depressive disorder, they usually mean bipolar 1. And specifiers just give us information about the most recent episode. They're useful for treatment purposes. You need to give specifiers when you're making a diagnosis. It's just useful information, treatment going forward. Okay? If I have bipolar disorder, I'm not always manic or always depressed. Most of my life, I'm right in the middle and thriving. Same thing with major depressive disorder. But there have been people who have met the criteria for major depressive disorder, and they've been on medication, and they've gone through therapy, and they've worked through a horrendous trauma. And sometimes when that happens, you no longer meet the criteria. That person might be able to go off medication. The course of major depressive disorder varies. The course of bipolar 1 disorder does not vary. When we talk about the specifiers, it's basically giving information on the most recent episodes. We're just going to talk about these as it relates to major depressive disorder and bipolar 1 disorder. Some of these specifiers, with peripartum onset, it used to say, prior to the DSM-5, it used to say with postpartum onset. Peripartum, which means any time before or after birth. If it is within 4 weeks of delivery, then we can give it a specifier. So if any episode, whether it's an episode of MDD or an episode of mania, we can say with peripartum onset. That's pretty important stuff to know because that can impact the treatment planning. With psychotic features, where is the psychosis in bipolar 1? These delusions of grandeur. They may be present, they may not be present, but if they are, we say it. We say bipolar 1 with psychotic features. That tells you right away, during the person's manic episode, they were delusional, delusions of grandeur. Someone could have major depressive disorder, no bipolar at all. I could get a diagnosis of major depressive disorder with psychotic features. It's possible. Sometimes a person's depression, but on top of that, they may hallucinate or they may be delusional. And they're often not delusions of grandeur. They're usually delusions of persecution. Don't think psychosis and automatically think of schizophrenia because we see psychosis and major depressive disorder sometimes. Another specifier is with seasonal pattern. That pattern can be environmentally based. Long periods of time where we have a lot of darkness. For some people, that triggers episodes of major depressive disorder. Same thing with mania. Not very much like could trigger an episode, but sometimes anniversaries. With melancholic features, melancholia is an old word for depression. If someone's got a diagnosis of MDD with melancholic features, that is really important because that tells us this episode of depression is really, really, really difficult to treat, and they're often resistant to medications. Not they, the person, the episode. Last one I'm going to give you is with rapid cycling. This is for the bipolar disorders. If it says bipolar 1 with rapid cycling, what that means is at least 4 episodes in 1 year. If I have bipolar 1 disorder, what could those episodes be? It could be 2 and 2, it could be 3 manic episodes and 1 MDD episode, at least 4 in a year. That's a lot, you guys. That's a lot of episodes in 1 year. So do you see where Hollywood kind of really steers us the wrong way? They make us think someone could be manic and depressed in the course of a day or two. That's not what this is at all. Some research says up to 50% of people with bipolar I meet the criteria for rapid cycling. And rapid cycling tends to be harder to treat, tends to be more resistant to medications. Not the person, the condition. So what medication does is it either pulls people out of the depressed episode or it pulls them down to the manic episode. Tries to get them back in that realm of healthy functioning. Gender differences, or gender disparities or discrepancies for the bipolar disorders, specifically bipolar I, 1-to-1 ratio. The onset major depressive disorder, it could be anything. So the age of onset for bipolar I disorder is usually before age 25. If someone has no episode of mania by the time they're 25 or 28, they're probably never going to have a manic episode. Statistically, it is very, very unlikely they will ever develop bipolar I disorder. Some research suggests that age is decreasing. Some research is saying that, it's certainly before 25, it might even actually be before 24, or somewhere early to mid-20s is usually when bipolar I surfaces. Can someone in their teens develop bipolar I disorder? Possible. Not likely, but possible. So statistically, it's unlikely, but it's possible. Comorbidity. 2/3 of people with bipolar disorder also have an anxiety disorder. 1/3 of people with bipolar disorder also meet the criteria for substance use disorder. In terms of suicide, I'm going to give you now, this is specific to bipolar II disorder. 1 in 5 people with bipolar II disorder attempt suicide. In bipolar I, 1 out of 4 people attempt suicide.